Communication, ethics and crisis management in critical care nursing, Coroners case study. Some of the many challenges nurses are presented with include managing the critically ill patient during stressful times such as patient deterioration. Statistics from the Australian Institute of Health and Welfare tell us that almost 1 in every 100 admission to a hospital in Australia will encounter an adverse event which may result in prolonged hospital stay, permanent injury or death. 1 in 10 critically ill patients admitted to an intensive care unit will be affected by an adverse event, with 50% of these being avoidable. With statistics this high, it is crucial that tools and resources are developed to facilitate change in managing patient safety and patient deterioration. This presentation will explore the importance of nursing communication, ethical decision-making, and crisis resource management in critical care nursing. We will use a coroner's case study to illustrate these concepts. To begin, we will define these concepts. Firstly, communication. The concept of communication relates to the use of appropriate terminology, language, tone, and gesture in discussion with the interdisciplinary team, the patient, and their family. It also includes advocating for the patient, escalating patient care, and clinical handover. Ethical decision-making. This extremely important concept focuses on adhering to legislation, local protocols, following evidence-based best practice guidelines, practicing within your scope of practice, being accountable for your decisions, and most importantly, considering the best interest of the patient. Crisis resource management. This looks at task delegation, team leading, being proactive, and positive role modelling. To highlight the importance of these concepts, we're going to utilise Coroner's case study. From 2017 to 2018, the Coroners Court of Victoria investigated over 450 cases of unexpected death that were caused by medical or surgical procedures. The case study we're going to explore fits into this category. We will first review the case, then discuss key findings, then critique the case, highlighting the deficiencies, and then discuss recommendations for future nursing practice, including those put forth by the coroner. Coroner's case overview. In 2007, a 75-year-old female, Mrs. YD, presented to a country hospital with symptoms of the flu and diarrhoea. Her past medical history includes renal impairment and hypertension. She was diagnosed with rapid atrial fibrillation and respiratory distress secondary to pneumonia. She was transferred to a hospital with an intensive care unit. She was in the intensive care unit for 8 days. After that, there were 2 attempts to extubate her, both which failed. Senior ICU Dr. H recommended a tracheostomy would benefit the patient. Junior Dr. B was to perform the procedure under Dr. H's supervision, even though he had no previous experience. Senior staffing was limited that day as it was a weekend and it was also late in the day. The nurses had provided a printed copy of the tracheostomy protocol to Dr. H, who ignored it and insisted he did not need it. According to the tracheostomy protocol, 2 consultants and the use of a bronchoscope were required. The ICU capnography monitor and the bronchoscopy were not available, and the replacement bronchoscope was not able to be connected to the monitor. Therefore, the procedure was attempted blindly. Dr. B did run into complications. Dr. H took over, but he was unsuccessful too. The procedure was not abandoned when they ran into these complications, despite the nurse's suggestion to do so. Eventually, a medical emergency team call was initiated after Mrs. YD's oxygen saturations dropped and she began to deteriorate. Shortly after this, she died. The death was reported to the coroner. Post-mortem examination showed the cause of death was septicemia secondary to pneumonia. with evidence of brain damage secondary to hypoxia. According to a forensic pathologist, the attempted tracheostomy was not the direct cause of Mrs. YD's death, but it did shorten her life. In terms of major findings, the coroner highlights the following. Neither of the doctors had previous orientation to the hospital or to the hospital's policies or procedures. Dr. H was a visiting locum intensivist who was on his last day of his rotation at the hospital the day the tracheostomy was attempted. The tracheostomy was a reasonable suggestion, but it was not urgent enough to attempt over a weekend, and using a bronchoscope may have prevented Mrs. YD from deteriorating. This is the evidence from the coroner's court. In terms of deficiencies, there are a few factors to consider. Firstly, the tracheostomy protocol was boycott. This occurred when the senior intensivist decided to attempt the tracheostomy over the weekend and in the afternoon, which is the most understaffed time in the hospital. Research tells us that this is when most major airway events occur, particularly ICU. This put the patient at high risk of adversity, and considering the procedure was not urgent, it probably was not in the patient's best interest at the time, and this reflects unethical decision making. Also, Junior Dr. B was practicing outside his scope of practice, which approaches medical negligence and breach of duty of care as defined in healthcare legislation. These actions also negate registration requirements. Also, breaching the protocol by not using a bronchoscope. We know that the use of a fibre optic bronchoscope can reduce the risk of adverse events occurring during a tracheostomy procedure. So we can see these are all unethical decisions made. Poor communication. Dr. B did not protest against the decision made by Dr. H at any time. Perhaps the hierarchical pressure, junior staff fearing challenging the authority of their superiors' decisions, forming a barrier in communication, particularly in this stressful environment. In terms of nursing, there was a lack of follow-up to ensure the protocol was adhered to. This indirectly put the patient at risk of harm, and under the Nursing and Midwifery Board of Australia, patient advocacy and the deliverance of safe and quality care fall within the nursing codes of conduct, which are also requirements for registration. And we can see that there was clearly insufficient assertive communication and patient advocacy, which likely contributed to the patient's detriment. This brings on the point of failure to escalate the patient's care. Unfortunately, in the case of Mrs. YD, there was a delay in escalation even though a MET call was called eventually. Deteriorating patients should be assessed using the primary survey following ABCD. That is, assessing the patient's airway, breathing, circulation, assessing disability and exposing the body to assess skin. Interventions should have been applied as they were identified. At the point where Mrs. YD's oxygen saturations began to drop, the situation should have been escalated immediately, and airway and breathing interventions such as oxygen administration, bag valve mask, and performing airway manoeuvres should have been initiated. The priority for Mrs. YD was to keep her airway safe to allow for adequate ventilation and ensure her oxygenation was adequate. We can see from the autopsy report that this was not achieved. This delay may have led to hypoxia and hypoxic brain injury. Perhaps the poor decision making was due to the stressful environment and the effects of emotion on cognition, and this definitely reflects poor crisis management. The patient's autopsy results ruled the primary cause of death as septicemia. The coroner made no mention of deficits regarding the management of the patient's sepsis. Therefore, we assume the patient received appropriate and timely treatment and interventions crucial in sepsis management, including intravenous antibiotics, hemodynamic monitoring, invasive monitoring, vasopressors, mechanical ventilation and fluids. Moving forward with some recommendations for future nursing. Firstly, closed-loop communication. As we previously explored, communication plays a very important role in healthcare. Strategies such as closed-loop communication include delegating tasks and direction, using people's names directly, confirming whether tasks or orders are received and executed. These are all effective forms of communication and should be considered for future practice. Graded assertiveness. As outlined by Trauma Victoria in 2019, teaching clinicians to speak up can build confidence in expressing their concerns and promoting safety. Some clinicians might disagree with their team leader and refrain from speaking up. This would be the best opportunity to practice graded assertiveness, a technique that allows anyone to challenge decisions they think that are unsafe or inappropriate. One way to remember is to use the PACE mnemonic. Firstly, to probe, then alert, challenge, and emergency. And you can see the examples there. An alternative to graded assertiveness is the 5-stepped advocacy approach. Firstly, getting the attention, raising your concern, stating the problem as you see it, suggesting a solution, and then obtaining an agreement. You can see the examples there also. Another recommendation for future nursing practice is crisis resource management education. This should focus on, firstly, leadership, teaching leaders to stand back and manage their team, avoid authority gradients by listening and accepting input, demonstrating firm and prompt decision making. Secondly, situational awareness and problem solving, so maintaining a bigger picture perspective, avoiding fixating through reassessment and reevaluation in an organised approach, thinking outside the box and rapidly implementing solutions. Thirdly, communication, as we've already discussed. Fourth, using resources, asking for help, utilising key staff members and sourcing equipment as required. And finally, maintaining a team mentality by providing support, clarifying roles, cross-checking and providing positive or constructive feedback. And here we can see the crisis resource management diagram again. We know that stressful environments can trigger emotions which influence cognition, and our behaviours and decision making may be affected, which leads to human error. So another suggestion for future practice is simulation training. Non-technical skill simulation training. This simulation training's been found to be very successful. This phenomenon is used in the airline industry with flight simulation, leading to increased confidence and competence through training in a risk-free environment, which ultimately leads to a decrease in error in real practice. Also, research has found interprofessional collaboration through simulation training very successful, where nurses and physicians train together in a simulated environment. This has been found to lead to improved collaboration in the real setting. Another recommendation for future nursing practice is utilisation of a crisis checklist. So these have been found to be beneficial, particularly in stressful environments. They're used in high-risk stressful environments such as nuclear power and aviation. And research shows these checklists improve crisis response by prompting decision-making following an algorithm that outlines the next steps that needs to be taken. You can see in this example, this crisis checklist is applicable to Mrs. YD's case. In addition to this, sepsis training is highly recommended. Nurses should reflect warning signs and be able to identify patients at risk of developing sepsis. But sepsis training would be very beneficial. Though the coroner made no mention there was any deficits, still it's a very important concept. Finally, the coroner put forth some recommendations which include formal orientation for visiting staff, including introductions to protocols and policies and the expectations that they have. Secondly, to monitor equipment and ensure that they're working and available, particularly in emergency settings and ICU settings. And thirdly, professional codes of conduct and codes of ethics be reviewed and followed where relevant to the healthcare professional. Communication, ethical decision making, and crisis resource management are essential in critical care nursing. We can see from the coroner's case, complications surrounding the failed tracheostomy procedure led to the deterioration and death of Mrs. YD. Some deficiencies included communication, ethical decision making, and crisis resource management. And the stress of the environment led to human error, which led to poor patient outcome. Some recommendations for future nursing practice include training in communication, in crisis resource management, training in simulated environments interprofessionally, and consolidating nursing assessment, particularly in sepsis assessment and management. And lastly, conducting orientation, following protocol, auditing equipment, and adhering to codes of conduct relevant to your specialty.